Good morning. Before I start, I want to thank Claudia and all the team at Epicentre. I have to say this is a very bizarre experience because I simultaneously feel like a kid or a very young person in front of the people that raised me, if you wish, and also very old because I see lots of people who are younger and who are following in all of our footsteps. So I was trained well, and we'll stand up here and we'll read what I'll give as an introduction, which wasn't easy to do for Ebola and Lassa, and I apologize in advance if I've forgotten anybody or any type of work. So Ebola is often described as a disease of compassion or a disease of empathy, and the people at the greatest risk are those who are caring for others, the caretakers, the friends, the families, the neighbors, the cleaners, the doctors, the nurses, because that transmission occurs through close contact, right, with bodily fluids. And it occurs often during caregiving, and it can also occur during funeral and burial practices. So when we think about that, throughout every major Ebola outbreak, from Kikwit in 1995 to West Africa in 2014, DRC in 2018, and today, even we see this with Bundibugyo, there's a disproportionate impact among those that care. Importantly, this is also true for Lassa fever, although its transmission dynamics differ a bit. Lassa is primarily zoonotic, and it's transmitted from rodents to humans, and then human-to-human transmission. And this occurs especially in hospitals and in households, and it's been well documented. Across outbreaks in Nigeria, Sierra Leone, and Liberia, it's those same healthcare workers and family caregivers who've consistently been among the highest risk groups, suffering a disproportionate impact. So those inadequate infection prevention and control measures, the shortage of equipment, delayed diagnosis, and they've repeatedly amplified transmission in both hospitals, clinics, informal centers, and at home. For MSF, both Ebola and Lassa have become defining diseases. They're emblematic of the commitment to responding rapidly to deadly epidemics in the most fragile and underserved settings. For more than 40 years, or close to 40 years, Epicentre has been a part of this, but always working closely with the WHO, with partners, with African research institutions, with ministries, with other NGOs, and international scientific collaborations. So Epicentre's involvement in Ebola dates back to the Kikwit outbreak, actually, in 1995. And this was the most defining epidemic prior to the epidemic in West Africa. It infected about 300 people, again, including a large number of healthcare workers and caregivers, and began to shape our understanding of infection prevention and control. During and after Kikwit, Epicentre has supported surveillance, outbreak investigations, field data systems, and clinical operations alongside MSF and all of its partners. One of Epicentre's most significant contributions came during the epidemic in 2014 to 16. During this crisis, Epicentre again worked alongside partners, but here it was to strengthen surveillance, to help analyze transmission patterns, to evaluate treatment center performance, and improve infection and prevention and control. In fact, at the origin of the outbreak, there was an Epicentre epidemiologist, Amanda Tiffany, who was in Gekadu, working alongside the teams there for MSF Switzerland, and then again with MSF Belgium, helping to identify the outbreak at its origin. This work largely transformed our understanding of Ebola, and Epicentre's work has helped to demonstrate this. During that outbreak, it was also one of the first times that there was more definitive information about transmission during funerals, caregiving networks, and also recognizing the fear-driven community behaviors that have contributed to transmission. All that was done at the same time that the flip side was also true. It was one of the first documentations about trust, decentralized care, and community engagement. Epicentre, however, has also played a key role in the development and evaluation of Ebola vaccines. During this outbreak in 2014 to 16, Epicentre participated in the ring vaccination trial, which evaluated the RVSV-ZBOB vaccine candidate, and this trial demonstrated efficacy against Ebola Zaire and became the pivotal evidence leading to the licensure of the world's first Ebola vaccine. The vaccine was also later licensed and WHO pre-qualified. Epicent and MSF also contribute to the deployment and evaluation of the second licensed Ebola Zaire vaccine. This was the Johnson & Johnson Ad26 MVA Philo. That's a 2-dose strategy, and it was used extensively in later outbreaks in DRC from 2019 onward. And again, all of these initiatives and all of these achievements were done in collaboration with many, many other actors. In parallel, it's also important to recognize that during the 2018-2019 Ebola outbreak in the DRC, Epicent also contributed to the PALM trial along with MSF. This was the first study that demonstrated that 2 monoclonals, Regeneron and MAB114, significantly reduced mortality compared to the previous standards of care. This trial transformed clinical management, and it was the first time that effective evidence-based treatment options were available for Ebola Zaire. All of these interventions fundamentally have changed the landscape of an Ebola response. For decades, Ebola was associated almost exclusively with isolation and supportive care and big Hollywood movies, which didn't help. And Epicent's work has always been embedded in this larger ecosystem. It's not to be unrecognized how this partnership and participation has shown both the core of Epicent, which is to ensure that the mission or the purpose, which is to ensure that other people's lives are improved, comes before working alone. I hope that all of the work that has been done in the past by Epicent and others in previous outbreaks will also show and contribute to improved acceleration for the Bundibugyo outbreak today. In terms of Lhasa, Epicent's visible engagement expanded quite rapidly around 2020-2021. And this has reflected the growing recognition within the wider community that Lhasa fever represents one of the most important neglected threats in West Africa. Lhasa is quite neglected, despite the fact that it causes thousands of deaths annually across West Africa. Nigeria alone now reports large recurrent outbreaks each year. Lhasa has become a strategic priority because of its growing epidemic potential, its, again, severe impact on health workers and families, and the major gaps that remain in diagnostics, treatment, and there's no vaccine. We hope there'll be one soon. Epicent became a partner in this at the beginning to help improve understanding of the epidemiology and burden of Lhasa fever in West Africa, working alongside partners across Nigeria, Liberia, and Sierra Leone. Epicent has contributed to one of the largest programs ever launched to document the burden of Lhasa, and these programs have aimed to answer fundamental questions that have remained unresolved for decades about Lhasa fever. How extensive are asymptomatic infections? Which are the populations at highest risk? What are the seasonal and geographic patterns of transmission? And how are we going to evaluate future vaccines and treatments? These efforts are helping to lay the scientific and operational foundation for future trials and advances in Lhasa care. So Epicent's role, with that of its African and international partners, has reinforced the understanding that healthcare facilities themselves are amplification points when infection prevention and control systems are weak. Repeated outbreaks recall and remind us all of the urgent need for improved protective equipment, rapid diagnosis, staff training, and safer clinical pathways in both cases. But Epicent's broader contribution has been to demonstrate that epidemic response cannot be separated from health system strength, trust, equity, and that research can and has always been embedded in these responses. This model, pioneering this model of integrated research, care, and response in humanitarian settings, where data collection, clinical care, epidemiology, and program implementation occur simultaneously, is rare. Epicent has been a pioneer in this, and I hope that it remains in that vein. This has really fundamentally changed how globally we understand how epidemics are studied and managed in emergencies. Just to finish, before I hand it over to Christopher, Epicent has brought also scientific attention to these populations and diseases that are almost always neglected by global research systems, demonstrating that it's possible and ensuring that we are in a situation where those that don't have a voice are heard by those who often have a tendency not to listen. So I'd like to introduce Christopher Mambula, who I have to admit is very difficult for me to introduce formally because I've known Christopher for a very long time. But I think it's worth explaining a little bit about him. So he's a medical doctor, he has a master's degree in public health, and he has over 20 years of experience with MSF. He's been in the field, he started in the field in Nigeria, and operational experience and coordination roles. Now he's based in Paris here at Jaurès, and he's the program manager who oversees operations for Central African Republic, Uganda, Malawi, DRC, and he's particularly interested in focusing on pediatric care, sexual and reproductive health, of course, epidemic response, and almost always in unstable contexts. Christopher.
Yes. Thank you very much, Rebecca. So I have the privilege of presenting Hugo Soubrier, who is an epidemiologist currently doing his PhD between Epicentre and the Charité University of Berlin. He was trained at the Imperial College and the London School of Hygiene and Tropical Medicine, and he has lab and field experience in the 2021 Ebola outbreak in Guinea. His research focuses on applying modeling and data analytics to support and improve the workflow of operational epidemiology in the context of humanitarian emergencies, especially during outbreak responses. So his current PhD projects are focusing on the transmission of Ebola disease using chains of transmission, which explains his presentation, which focuses on quantifying the heterogeneity and determinants of Ebola Zaire transmission, insights from the 10th DRC outbreak. Hugo.
Thank you very much, Chris and Rebecca, for the introduction. So yeah, it's my pleasure to be here. I hope this will give you some insights on Ebola Zaire transmission. But first, let's start with a bit of context. The outbreak we will be speaking of is the 10th Ebola outbreak in DRC that occurred between 2018 and 2020 across the north provinces of Ituri, North Kivu, and South Kivu. The outbreak was the second largest ever recorded outbreak of Ebola, with more than 3,400 cases, an overall case fatality rate of 66%, and was caused by the Ebola Zaire virus. Now, this outbreak was characterized by numerous security incidents, including attacks against the response activities, but it was also the first outbreak where ring vaccination were deployed very early on, alongside the traditional pillars of an Ebola response, including the now famous contact tracing activities. Now, throughout the presentation, I will be talking about chains of transmission. It's a concept you may have heard from other diseases like COVID and antivirus, but it's particularly relevant for Ebola. So, simply put, a chain of transmission is a type of representation of infection event where we try to answer one simple question: who infected who? To do this, epidemiologists have two approaches. Let's assume we have 4 infected Ebola cases. If the activities are well in place and that these cases are identified early enough, we can register, follow up, and monitor all of their contacts. This is commonly known as forward contact tracing and is routinely done in Ebola outbreaks. Now, some of these contacts will develop the disease and therefore be assigned as secondary cases of our main cases. Some of them will not get the disease and will be excluded from the chains of transmission. In parallel to this, epidemiologists can conduct very extensive and meticulous case investigations where they retrospectively link cases to their known infector. Now we can combine both approaches and reconstruct the so-called chains of transmission. Now, as you can see, this process is imperfect, and we typically end up with these kinds of chains where we have missing links and cases completely unlinked. Nevertheless, these are very valuable pieces of information that we can use to better understand the transmission profile behind the disease. And this is exactly what we've been doing with this retrospective analysis. What do chains of transmission on this outbreak tell us about the outbreak itself? We will be focusing on 3 things. First, we looked at the missing transmission links and see what they tell us on our response. Then we had a look at the number of secondary cases and understand how was transmission distributed. And finally, we looked at case characteristics and what they tell us on the drivers of this transmission. Let's start with the missing links. As I just said, the chains of transmission are only partially observed, mainly due to challenges during contact tracing. What we see in our outbreak is that 56% of our cases were linked to their ancestor or infector. These are in blue in the mock chain, and 44% of them could not be linked to their infector. Now we can take these and look how they're distributed across time. And if we classify cases based on if we know or don't know their infector, then we can retrieve the proportion of cases that were linked every week. Now, simply put, what we observe is that right before the peak, this proportion of cases linked to their infector was very low. It was about 20% by December 2018. Now, as the epidemic progressed, the proportion of cases linked to the infector greatly improved, up to 80% by December 2019. Now, recall that this outbreak was characterized by many security incidents. If we look at, including 9 attacks on healthcare centers, healthcare workers, and health centers. Now, if we look at the timing of these events, which are in yellow here, we see that they very neatly overlap with our periods of lower case linkage. So keeping in mind that this is probably a multifactorial process, it does seem to tell us that violences impacted the quality of the contact tracing and thus lowered our ability to see and reconstruct the chains of transmission. Now let's move to the number of secondary cases. So here the question is simple. How was transmission distributed? And to do this, I'm going back to our simple chain, but for simplicity, we're assuming that it's fully reconstructed. Just know that in our analysis, we are adjusting for the missing links. The first thing we see is that a vast majority of cases do not infect anyone. It's 73% in our outbreak. A much smaller proportion of cases infected one person, 23 people infected 5%, and then a merely 17 people infected more than 10%, with one individual infected up to 29 people. So simply put here, what we see is that we have a vast majority of people who do not infect, and a tiny proportion of cases who infect a huge proportion of them. This is commonly known as heterogeneity in transmission. And we say the transmission is heterogeneous, and we can better describe it by saying that 80% of cases were infected by only 18% of cases. Now, if we look at this minority of cases who contributed to the biggest part of the outbreak and see how they distributed across time, that's what we see. And these are in red here. Now, very roughly speaking, we observe that this heterogeneity is stable across the outbreak, especially before the peak, during the episodes of violence, during the period where transmission was highest, right after the peak, and at the end of the outbreak, always fluctuating around 20% of cases infected 80% of them. Now, all this together tells us many things. First, we know that there is heterogeneity in Ebola transmission. It was described for the West African outbreak, and we are showing here that it's also present in DRC context. It seems to be an inherent feature of Ebola transmission and needs to be continuously monitored during ongoing and future outbreaks. Now we see that this heterogeneity is stable, especially during the violence. Other periods are increased transmission. It means that during the peak, on average, everyone transmitted more, but the level of heterogeneity remained the same. To us, that means that during these periods, what we see is the transmission profile of the disease did not change. What changed was our ability to act on it due to incomplete response activities. Now let's move to the case characteristics. We've just seen that some cases transmit more than others, and we also know they've got characteristics, for example, the isolation status. We have all these informations. So what we can do is we can explore the association between the number of secondary cases and these variables of interest. So let me note here that all the results that will be presented are adjusted for the missing links and for the confounders. We first started to look at the response pillars, our core response pillars, and how they impact transmission. The first thing we see is for isolation. Cases never isolated had 1.79 more secondary cases than cases that were isolated in our ETCs. In terms of contact tracing, we observed that cases that were never registered and never followed up had, on average, 4.5 more secondary cases than cases that were never registered and never followed up. When we look at vaccination, we see that cases that were not vaccinated had, on average, 3 times more secondary cases than cases that were vaccinated. Now, all this tells us, we emphasize and it quantifies the importance of these core response pillars. We know that rapid isolation, successful contact tracing, and ring vaccination cut transmissions. Now, when we looked at the other variables of interest, it gives us insight on the mechanisms of this transmission. What we see is that all the variables which are proxies for prolonged time in the community while being infectious, such as never being isolated, dying outside of an ETC, not being registered as a contact, or the more days you spend in the communities, are all very strongly associated with higher transmission. Now, variables which are proxies for severe disease, such as wet symptoms or higher viral load, they're also associated with higher transmission, but to a lesser extent. Finally, we could not find any evidence of an association between increased transmission and the occupation, including a transport occupation or healthcare workers, but also sex and age. So that was a lot. Let me wrap all this together. If there are 3 things I want you to retain from this analysis of the chains of transmission of the 10th outbreak, is that first, there is heterogeneity in Ebola transmission. We know that it is stable, and we need to continuously monitor it. Now, the second thing, our main our main response activities, namely effective contact tracing, rapid isolation, and ring vaccinations, are effective at cutting down transmission, and mainly because they reduce the time that infectious individuals spend in the community. However, we know that attacks on healthcare centers, but also on the response, and overall community mistrust impacted our ability to effectively conduct these activities. So I know Ebola is scary, but it's important to note that Ebola is controllable, and we have the tools for it. Now, the main challenge is how to effectively apply those tools. And it must start with long-term trust-building community engagement in the community we're working for. Now, I hope with this presentation that you will understand chains of transmission are valuable during and after outbreaks. Also know that we have models to infer these chains of transmission and reconstruct them, even in the field with partial data. And let me remind you that all this work was about Ebola Zaire virus, and it needs to be done for the current Ebola Bundibugyo outbreak. With this, let me thank all the people I've been working on. And I guess this presentation is dedicated to everyone involved in the current response, whether it's from the field up to the computer. Thank you very much.
Thank you very much, Hugo. So we will proceed to the questions and the discussions. To make it a bit more fluid, I think I will pass you a microphone, and either you, I guess I can ask Laura to just come up, and so it will be easier to respond. 2 things I've retained from, 1 thing each from the presentation. So for Lassa fever, interesting to note that even though it remains a relatively rare disease in the West African context, the reality as well is that we do have quite a lot of work to do in terms of advancing trials on vaccines. And also, it has shown that due to the relatively low incidence, that we would have to have relatively large sample sizes when we conduct these vaccine trials. And for Ebola, also interesting to see that 80% of patients or people who have been confirmed as positive do not actually transmit, which is a good thing, I would say. Now, the question is, what is driving that? Is it the factors and the measures that we put in place, as he mentioned, isolation, follow-up or contact tracing, and also vaccines and or treatments that are available, is to be seen. You could make that link because in the latter part of the epidemic, as he showed on his graph, you could see that, in fact, there was declining transmission. In fact, most of the transmissions happened at the very beginning and at the peak of that epidemic. That said, we will pass to questions, comments in the crowd and also online. If you're online, please feel free to send in your comments or questions as well. So over to you.
Post-mortality transmission. So I know, for example, in the 2014-2016 Ebola outbreak, transmission at funerals from the body to the mourners was a very serious and important aspect. And the challenges of making those funerary practices safe caused also a lot of friction with communities who understandably wanted to mourn appropriately. Are you able to include that? Is that an aspect of the statistics that you've done? So when you say, 0.7% produce more than 29, is that included in that? Okay, thank you.
I will repeat that question in a very, very short sentence for the translators. Essentially, the question is concentrating on post-mortem transmission, if I'm not mistaken. I think you got the question, so you can respond.
Yeah, so thank you for the question. Yeah, I was expecting this, actually. So just know the chains of transmission, they're reconstructed, and we know someone infected X amount of people. But we don't always have exactly the reason or the context of infection, and it wasn't very clear from our data. So when someone infected 29%, it might be possible that this is actually a funeral event. But I don't have exactly those details, so it was really hard to look specifically into these types of event. Now, know that there is also a very strong association between dying outside of the ETC and secondary transmission, which we could assume includes in there these post-mortem events.
Thank you, Hugo. Please go ahead with your question.
Oui, bonjour, Mathias, Université.
My name is Matthias, Bordeaux University. I'm going to ask my question in French, if you don't mind. Now, the outcome of forward contract tracing, well, it has some implications, I'd say. And do you think there's still some added value of doing forward contact tracing, because 80% of some zero secondary cases could not be seen as valid, and it seems that also backward contact tracing, as seen with COVID, could be very useful to identify a context in which transmission took place, like burial, for instance, or no, have.
Okay. Oui, alors, donc déjà, il faut savoir dans les chaînes là qu'on.
Well, you have to know that in the chain that we have reconstructed, there are two things. There are backward and forward tracing, because we can identify cases that are all linked to the same event, so we can trace them backwards. Now, is it still useful to use forward contract tracing? I'd say yes, because all these people who haven't been traced back and not followed up, we can see an increase in the number of secondary cases. So I think we need to go on with forward tracing. And as Etienne explained to me yesterday, I think we should not impose it. I think we should convince people that it is important for them. If they were in a risk situation, they have to be followed up. So the forward contract tracing can work only if you build up trust with the community, and you can rest assured that people are going to get in touch with you to tell you about what happened to them. I'd like to also say that the lack of trust and the mistrust in the communities vis-à-vis the community health workers or health workers is a problem in terms of contract tracing and transmission alike. And we can see that with the current outbreak. There were already 2 serious incidents, as far as I know, targeting health centers because of this mistrust. So I think we need, all of us, we need to work so as to improve the situation and the trust with the communities.
Thanks for the presentation. I think super interesting to kind of see this 2080 kind of principle apply to Ebola, because it applies actually, as we know, for most infectious diseases, right? And I think indeed the pivotal question, if you look, for example, at malaria, it's always quite clear that you can clearly identify hotspots, for example, on seroprevalence. And indeed, the key question pertains to what are the risk factors. And I think most of us with the operational experience know exactly what those risk factors are and where you see mass infections taking place. So I think I see a study more as like a kind of like a theoretical confirmation of the fact that, yes, if you want to pinpoint your interventions, this is where you should pinpoint them. Burials that don't go well, or areas where you deal with big households where things go unnoticed for a long time, multi-generational households, for example. And the question was kind of asked, like, how do you pinpoint that a little bit better, as in, like, how do you translate this 2080 to where we should target interventions, or maybe not target interventions, but should focus more on? And I was wondering if you could elaborate slightly more on that. And then the second part is, as malaria also kind of like ongoes during an Ebola outbreak, I think the 2080 principle is also quite useful to bring forward for the other diseases under the underlying aspects that cause huge amounts of mortality. I know we look at MDAs, but MDAs will not always be
Hey,
feasible.
Amrish, can they start responding?
Yeah,
Because
go
we're
ahead.
losing you in the back. Hang on one sec, sorry about that.
Yeah, so if I got the first question, it's basically how you translate all this into operational outputs. And I guess everyone here might be surprised that I never used the word super spreading in this presentation, and super spreaders. And there was a lot of questions about who then are exactly those people who transmit a lot. Well, we never used it because super spreading and super spreaders requires you to set a threshold somewhere on, like, what is super spreading? Is that 3 people? Is that 4 people, 5 people, 10 people? And as you can see, the number of people who infected more than 10 is extremely low out of 3,400 cases. So that's why we never set that threshold. So we're not doing an analysis where we look at what makes you at risk of being that super spreader or not, because we decided not to put that threshold. Instead, we're looking at the factors that contribute to the overall increase in transmission. So I know it's hard right now to translate this into operational outputs. In terms of, like, who should we target, like these people. What we try to show in the presentation is at least our core pillars are working, and the variables that are really associated every time are basically the people who spend a lot of time in the community while they're infectious. So we don't set any threshold. What we say is, as soon as people are infectious, they should not be roaming in the community, or, like, as least as possible. And do you want to follow up on your other question? Sorry, Amrish. Is that fine?
Okay. All right, there's one question online, and then we can go back to the room. There's a clarification question for Hugo. Can you explain why you stated that during the peak, each case transmits more, while the heterogeneity remains stable over the course of the outbreak?
Yeah. Basically, what you see during the peak, that there is an increase in transmission. So people infect more. Now, it's not that the way people infect is exactly the same. It's always a minority that drive the infections, and the vast majority do not infect. But let's say the vast majority now infect 2, but you have the ones at the tail of the distribution who basically infect even more. So the whole distribution gets shifted. So, like, more people infect, but the heterogeneity still exists. It's not like everyone starts to infect the same number of people. I don't know if that was very clear. I can speak with people.
Thank you very much. Of course, have some discussions during the pause. Thank you very much.